Hello, I'm Matteo Colombo, I'm Scientific Communication Manager of Bioteck, and today I'm gonna present you the Xenomatrix, that is our three-dimensional collagenic matrix to have a faster regeneration of the soft tissues. Xenomatrix is available in two different formats, so BCG XC50, that is indicated for the treatment of gingival recession, and BCG XC10, which is indicated for accelerate the soft tissues regeneration in post-extractive sockets. We start talking about BCG XC50, so for the treatment of gingival recession. So gingival recessions include 88% of the population that is at least 65 years old and 55% of the population that is between 18 and 64 years old. Then recessions are more frequent on the vestibular surfaces, and the monoradiculate tooth have a higher frequency of gingival recession compared to molars. So how to predict the possibility to reach the complete root coverage, so to completely resolve the gingival recession? To do this, there were many classifications of gingival recession that have been proposed over the years, and the most accepted now is the one from Cairo, developed in 2011. And here are the three different classes that he developed, based on the interproximal clinical attachment level. And as we can see, he identified three classes: RT1, RT2, RT3. As we can see, the RT1 is the mild class, so the one that can, for which is possible to predict a complete root coverage by a surgical intervention. And this is due to the fact that there is the absence of the loss of interproximal insertion. We see that we have the loss of we have the gingival recession just over the root of the element. This corresponds to the old classification of class 1 and 2 of Miller, while RT2 is a bit more severe than RT1, for which is not possible to predict a complete root coverage. And we see that in this case we start to have an interproximal attachment level, and this corresponds to class 3. Then with R3 we have a very severe condition in which we have the loss of interproximal insertion that is more than the vestibular insertion loss. We see here that is completely there is a complete loss of soft tissue, and this corresponds to Miller class 4. Xenomatrix can be used to treat RT1 classified gingival recession, and in this case we can have a 100% recover of the gingival soft tissue. How to treat this type of gingival recession, so RT1 recession? One of the most used surgical technique is the CAF or MCAF when there are multiple gingival recession. CAF stands for coronal advanced flap, and it can be used in patients with at least 2 millimeters of keratinized soft tissue. Also, this technique can be accompanied by the connective tissue graft harvested from the palate in order to have a better stability of the soft tissues. Okay. However, this harvesting of the palate, of course, it's something that is not the best for the patient, no? Because he has more pain, there can be more complication, post-operative complication, and so here comes the need for the Xenomatrix, for the collagenic three-dimensional matrix, in order to avoid the morbidity associated with the harvesting of the palate, and it can be used when there is at least 1.5 millimeter of connective keratinized tissue. And these are the issues related to the palate harvesting for the connective tissue graft. Indeed, this resume saying that in the donor side, so the palate, to extract the connective tissue graft is associated with more complication for the patient, and particular in this way we need an alternative to reduce this pain, the inflammation, and so to avoid the lesion of the palate harvesting. And over the years has been demonstrated that the xenogenic matrices can be used to regenerate the keratinized tissue of the tooth and of the implants, associated of course with the techniques that I've mentioned before, so the CAF or MCAF. In this way it improves the healing of the soft tissues. The collagenic matrices reduce the time of the surgery and also the postoperative pain, so reduce the consumption of drugs for the pain, and also they improve the aesthetic of the treated region. So the BCG XC50, it has these dimensions, so 50 millimeters times 30 millimeters times 4 millimeters of thickness. Its properties is the high hydrophilicity. It doesn't require prehydration, and also it allows to promote, to favor the formation of new connective tissue. Here we see this electron microscope view, where we see the interlaced collagen fibers that constitute the BCG XC50, that is derived from equine tendons. Again, these are the advantages of BCG XC50. It is easy to apply. It allows a surgery that is more rapid, it's faster and less invasive, because it avoids the harvesting from the palate of the soft tissue. And also we have with Xenomatrix a better aesthetic by the fact that the soft tissues are thicker. As we can see in this scheme, it is how it should be used for the treatment of gingival recession RT1. So it is necessary, once identified the gingival recession, to see which can be the maximal level of covering of the root to be obtained. And so this is the dashed line indicating where the gingival margin should be to cover the recessions. If it is necessary, the matrix can be cut when it is dry. in order to adapt to the size of the recessions. And then these are the incisions that are made to elevate the flap. Then the Xenomatrix, as we can see, is put in order to reach the planned height of the soft tissues. And then there is the suturing, and with the healing at the end, the completely coverage of the root of the teeth involved. So these are the clinical evidences available for BCG XC50 for the gingival recession. We have this study, retrospective study from Dr. Giacomo Tarquini from Rome, where he compared 32 recessions treated with the palate harvesting, so with the connective tissue graft, and 25 recessions treated with BCG XC50 with Xenomatrix. And these are the results he has obtained. We see that at the baseline they have a similar depth of the recession, so more or less 3 millimeter, while at 1 year follow-up both of them were decreased down to 0.2 more or less millimeter, so both of them worked if we consider all the recessions treated, because in this study there were class 1 and class 2 based on the old classification of Miller, so we say RT1 now. Say this all recession correspond to RT1 classification of Cairo, and as we can see, both of them reach more than 95% of total root coverage. That is the parameter to assess the success of the procedure. At 1 year of follow-up, both Xenomatrix and the connective tissue graft worked well, but with the difference that with the connective tissue graft, the patient experiences the discomfort of the palate harvesting with basically a hole that the patient have for some time, while in the case of the use of Xenomatrix, this part is completely disappeared, and so it is faster than also the procedure, because there is no need of preparing the connective tissue graft to be inserted into the point of recession. And here we have other clinical cases with Xenomatrix. So this is a case with multiple recessions, as we can see from this initial figure. So the Dr. Nicola De Rosa of Naples started with the incision of corresponding to the coronal advanced flap. He prepared the Xenomatrix with a bisturi, and here we can see the application of Xenomatrix that becomes really, it acts really like a sponge, because it is highly hydrophilic. It takes the blood that has been exposed during the surgery, and then the matrix is stabilized with suture, and then we see the complete coverage of the root, the disappearing of the gingival recession, and we see that the restoration is complete at 1 year from the surgery, and we notice also the increased thickness of the soft tissue that also results in a healthier apparatus of the tooth. Here we have another case from Dr. Riccardo Stefani from Venice. Again, in this case, multiple recessions, some treated with Xenomatrix, some treated with the connective tissue, and we see here the Xenomatrix and here the connective tissue. And we see that the results at the end, at 1 year from the surgery, were comparable. So in this case again, we see that the performance of Xenomatrix is similar to that of connective tissue, but without the problem of harvesting the connective tissue from the palate. Here again another case of Dr. Giacomo Tarquini on RT2 recession. We see the application of Xenomatrix here, and the coverage with the flap, and again here at 18 months of follow-up and 2 years follow-up, and finally at 6 years, so we have a very long-term follow-up showing that the root coverage is maintained. So with BCG XC50 we can obtain the complete coverage of the recession of type RT1 that correspond to the old class 1 and 2 of Miller. Using the bilaminar technique with the Xenomatrix improve the aesthetic results and also the stability of the tissues comparing with the CAF or MCAF alone. There is an improvement of the vascularization, so this of course it becomes better for the healing of the recession. At the end also the aesthetic results is optimal, as we have seen. There is also the increase in the thickness of the soft tissues, resulting also in a healthier gingiva. We have talked about the gingival recessions. Now we talk about the BCG XC10, the format of Xenomatrix to treat the soft tissues after post-extractive socket. Here it is known that after the extraction of the tooth, the alveolus start a process of resorption that can reach about 50% of the initial volume in the first 6 months. And this, of course, it's quite a problem if the patient want to go with the implant rehabilitation, because we know that there is a loss of volume, then there is not enough bone to place the implant, and also together with the resorption of the bone, also there is a degradation of the soft tissue, let's say a kind of restriction, no? Because there is not enough bone, and then also the soft tissue start to collapse. But in order to provide and facilitate also the surgery after the extraction, it is possible to use the Xenomatrix in order to protect the bone graft that is used to avoid the resorption of the bone, and so to favor the healing of the soft tissue by second intention, so without the need to open flaps. And from a surgical point of view, this it's better, because we have also in this case less possibility of post-operative complication. So Xenomatrix BCG XC10 is given in this size, 38 by 16 by 4 to 14 millimeter in diameter, and it has basically the same properties, because also is derived from the equine tendon as the BCG-XC50. It has the same properties, high hydrophilicity, it doesn't require prehydration, it promotes the formation of new connective tissue, and in this case also it protects the bone graft for the first 2-4 weeks and stabilize the clot. We see the same figure of the electronic microscope, showing again the different collagenic fibers. The advantages of BCG-XC10: it is easy to apply, it allows a faster surgery and less invasive, because it doesn't require to opening the flaps. It is possible to have a second healing of the post-extractive socket, and also it improves the soft tissues, so improves the aesthetic. So BCG-XC10, as we have seen, is indicated specifically to favor the healing of the soft tissues in the post-extractive socket. Here we have the scheme of its usage. As we can see, we have a patch A and a patch B. This is the post-extractive socket. Here there is the cleaning, the preparation of the alveolus. There is the insertion of granules, so of bone graft, in order to favor the, let's say, to keep the volume in preparation of implant rehabilitation. And then there is the application of the Xenomatrix. So first of all, the patch A is embedded in the gingival flap here, and then the patch B is put inside, and over it is closed the patch A. Also, some doctors use separate the two, patch A and patch B. Patch A is used for larger tooth, such as molar, and patch B is used for smaller tooth, so such as canine, for example. So here it is how it looks like when the graft is covered by the two patches, and then in this case the Xenomatrix is stabilized by sutures. There are no sutures inside the matrix, but just over it, in order to keep it stable, and it is left exposed, so without the need of opening the flaps and cover the Xenomatrix. This is because it's quite thick, and so it protects the graft, and at the same time it is the good substrate for fibroblasts, for the soft tissues cells to regenerate. And here we see some clinical evidence. This is a case report from Dr. Alessandro Leonida from Milan. We see it is very well explained in these images they use, because we see the preparation of the socket, the insertion of the graft, and the coverage with the Xenomatrix that is left exposed and stabilized by these suture stitches. And here there is the healing at 7 days. We see already good healing of the soft tissue. And here at 3 months there is the perfect, we see the perfect healing of the soft tissue around the implant. This is another case from Luca Lamazza from Rome. Again, the same technique. From this molar there is the extraction, then there is the grafting with OX, and then the Xenomatrix covering the graft and stabilized with the suture that are just keeping stable the Xenomatrix without movements. And here we see the progressive healing of Xenomatrix. This is the initial healing of the Xenomatrix with this fibrin layer. And we see again this aspect at 14 days. At 28 days we see now a soft tissue more mature, and 42 days basically is completely healed, as well as 5 months where it is ready for having the implants. Also we see that the good result of OX, let's say of the bone graft that results in enough quantity of bone to place the implant. Here we see this case from Professor Renzo Guarnieri from Treviso. Again, there is the extraction of a tooth. I put the graft, and the Xenomatrix is put well within, and it is left partially exposed with the sutures. And 30 days already looks like completely healed. And here it is interesting because also in this case he used collagenated granules of osteoxane line. So we see at 3 months it seems like there is no bone there, but this is due to the radiograph artifact with OX granules, because at the beginning they are not appearing as the same opacity of the basal bone, but then progressively they are remineralized by the cells, so they are remodeled, so they are completely, the granules at the end are completely replaced by the bone of the patient, and we see that the aspect is completely the same as the basal bone, and so it was possible to place the implant. And here also he took a biopsy when I put the implant. We can see here the new bone formed. It is asterisk. The bone that is maturing. And here we can observe this osteoclast, so the cell that is going to digest the granules of the equine bone. So there is still some granules to be remodeled, and the osteoclast is making the job. So to conclude with the Xenomatrix BCG XC10, it is the format that favors the soft tissues formation, regeneration, and also promote the adhesion of fibroblast. And the result is a healing much faster, and also reduces the pain for the patient and possible complications, also obtaining a better aesthetic result. And this is something that is due to the fact that it avoids to opening flaps that can result in more discomfort for the patient, and also it is more difficult for the surgeons to make the operation. So this is all for today. If you have questions, you can write at the email address that you see in this slide, so m.colombo@bioteck.com.